LH act on the testes in the males, act on the ovaries in the female. In the female, the ovaries produce estrogens and progesterone, which have a negative feedback on the pituitary and the hypothalamus, whereas in the testes produces testosterone, which has a negative effect on the pituitary and the hypothalamus. Other pituitary adenomas, thyrotropes, TSH producing adenomas, they are rare. Non-functioning pituitary adenomas are there. It can have mass effects. Pituitary carcinomas are also quite rare. The majority are functional neoplasms with prolactin and ACTH being the most common secreted products. Any query in hyperpituitarism? Please ask me. You can write in the message or you can unmute your mics. Any question, any query, please ask me before I go ahead. No? Okay, now we come to hypopituitarism. Decreased secretion of pituitary hormones due to, it can be due to diseases of the hypothalamus or the pituitary. They may be congenital or acquired. The patient may have single or multiple hormone deficits. There can be tumors and other mass lesions. Any mass lesion in the sella can cause damage by exerting pressure on the adjacent pituitary cells. I told you this before. Any mass which is present in the sella near the pituitary or in the pituitary itself, non-functional large pituitary, it can cause damage to the adjacent normal pituitary also. Traumatic brain injury and subarachnoid hemorrhage common among the most common causes of pituitary hypofunction. Some injury to the brain, some subarachnoid hemorrhage, pituitary surgery or radiation. Any if there is a pituitary adenoma, maybe non-functional surgery. The surgery is done of that pituitary gland, and by mistake, with the abnormal pituitary, portion of the normal pituitary is also removed, and that can cause hypopituitarism. Similarly, with radiation, pituitary for the pituitary tumor, you give the radiation which damages the adjacent pituitary normal parenchyma also and can cause hypopituitarism. Then there is pituitary apoplexy. There is a sudden hemorrhage into a pituitary adenoma. There can be a pituitary adenoma. Sometimes there is sudden hemorrhage inside a pituitary adenoma. Then what happens because of this? There is mass effect also, and there is, because of the hemorrhage, and I think there is sudden hypopituitarism. So pituitary hormones have a sudden drop, also the sudden mass effect. So because of both the things, it becomes a neurosurgical emergency. It can be sudden death. There is sudden severe headache, diplopia, and hypopituitarism. It can cause cardiovascular collapse, loss of consciousness, and sudden death. It becomes a neurosurgical emergency. Okay. Then there is something which is called Sheehan syndrome. What is this? In pregnancy, when a woman is pregnant, the pituitary gland enlarges to about 5-6 size to cope up for the hormones which she needs for the development of the fetus. So the pituitary becomes enlarged, almost double the size, but the blood supply of the pituitary does not increase, it's the same. So the pituitary is working in a state of partial hypoxia. Now, at the time of delivery, what happens is, supposing there is postpartum hemorrhage, or the patient goes in shock, or for some reason the blood supply becomes less, it goes in hypovolemia. What will happen? The pituitary, already it was going in a low state of oxygenation, now there can be ischemia of the pituitary gland. There can be ischemic necrosis of the pituitary. And this is called Sheehan's syndrome. Then can be empty sella syndrome. Enlarged empty sella turcica can be due to ablation of the pituitary by surgery or radiation. Hypothalamic lesions, hypopituitarism accompanied by evidence of posterior pituitary dysfunction. Usually what happens is, when the anterior pituitary or usually the hormones of the anterior pituitary are disturbed. Sometimes you find that along with the anterior pituitary hormones, you find deficiency of the posterior pituitary hormones also. That is, diabetes insipidus is also there. So in that case, it is more likely that this is due to some hypothalamic lesion. So hypothalamic lesion, remember, both the anterior and posterior, both the lobes of the pituitary will become abnormal. So you will find evidence of anterior pituitary hormone deficiency as well as posterior pituitary hormone deficiency. Inflammatory disorders and infections like tuberculosis, sarcoidosis, they can also cause hypopituitarism, and genetic defects which can cause hypopituitarism. Clinical features are variable. Again, it depends on which hormone is being not secreted. Right? Deficiency of growth hormone in children can cause growth failure, pituitary dwarfism. Right? If there is a growth hormone deficiency, children can have dwarfism. Now, how do you diagnose a case of decreased secretion of growth hormone? Basically, you try to stimulate the growth hormone. So this is diagnosed by insulin tolerance test. This is a confirmatory test for growth hormone deficiency. What you do is you give the patient insulin. Excuse me. You give the patient insulin, and so that the patient goes in a state of hypoglycemia. Goes about when the blood glucose falls to about 50 milligram per dl or so, the patient will go in hypoglycemia. At that time, you take blood for growth hormone levels, and immediately you give the patient IV glucose so that the person does not. It's a risky procedure. The person can die. So when the patient goes in hypoglycemia, at that time there is a peak level of growth hormone. So you can find out if there is growth hormone deficiency or not. This is a growth hormone stimulatory test. Insulin tolerance test. This is considered to be a gold standard or a diagnostic test for growth hormone deficiency. Lack of gonadotropins, FSH and LH causes amenorrhea and infragility in women, and decreased libido, impotence, and loss of pubic and axillary hair in men. Okay. ACTH and TSH deficiencies result in symptoms of hypothyroidism and hypoadrenalism. Prolactin deficiency can cause failure of postpartum lactation. Pallor, MSH is synthesized from the same precursor as ACTH. Pallor is due to lack of the stimulatory effect of MSH on the melanocytes. If the ACTH, the corticotrophs are not producing properly, they will not produce POMC, they will not produce ACTH, they will not produce MSH. So there will be failures, there will be pallor because the melanin will not be produced. There will be fatigue, weakness, sexual dysfunction, regression of secondary sex characteristics are the most common presenting symptoms. And in the lab, you will find hypoglycemia and hyponatremia. Endocrine effects depend on the pituitary hormones involved, low serum TSH and thyroid hormones. They can be low ACTH and cortisol, they can be low FSH and LH, they can be growth hormone deficiency or a combination of any. I told you again, hyperpituitarism as well as hypopituitarism, any one hormone can go or all hormones can go. So you don't know which is there. But the classic finding in the following order. First, the gonadotropins are disturbed in hypopituitarism. First, the gonadotropins are disturbed, then the growth hormone, then TSH, and then ACTH. But this pattern may not be followed. It is in medicine, there is a rule that nothing is 100%. No, it can be, but most probably it doesn't. You don't know, you can't say. Okay, any query you have with the pituitary hormones, anterior pituitary hormones, please write in the chat or unmute your phones, microphones and ask me. Any question, any query? No? Okay, now we come to the posterior pituitary hormones. Two hormones are secreted by the posterior pituitary. One is ADH, antidiuretic hormone, also called arginine vasopressin, and second is oxytocin. We will discuss ADH in detail. Oxytocin is involved in contraction of the uterus during parturition and also facilitates lactation. Now, diseases of the posterior pituitary, diabetes insipidus. This disease is due to deficiency of ADH. Now, what is the work of ADH? Basically, ADH, the work of ADH is to reabsorb water from the kidney tubules. When the kidney is there, the kidney tubule is reabsorbs water, and so that there is more water left in the body, and the urine becomes concentrated. If there is ADH deficiency, water cannot be reabsorbed from the kidney, so all the water is lost in the urine. If there is excessive urine loss, that is called polyuria, and this is due to the inability of the kidney to reabsorb water properly. Causes of diabetes insipidus include head traumas, tumors, inflammatory disorders of the hypothalamus and the pituitary, surgical procedures involving these organs, or it can be simultaneous, spontaneous in nature. Now, there are two types of diabetes insipidus. One is central or neurogenic. If there is a deficiency of ADH, ADH is not being produced properly. It is central or neurogenic diabetes insipidus. If the ADH is being produced, but there is some kidney problem, the kidney is damaged or the kidney is unresponsive to the circulating ADH, the renal tubules are unresponsive to the circulating ADH, then it becomes nephrogenic diabetes insipidus. ADH is all right, but the kidney has some problem. So it can be neurogenic or it can be nephrogenic. The clinical manifestations of diabetes insipidus, there is excretion of large volumes of dilute urine with low specific gravity. So urine is diluted. Loss of water, lots of water are lost, so it is a dilute urine. Serum sodium and osmolality are increased. Because of the loss of water, comparatively sodium levels rise in the body. Sodium does not increase as such, but because of the loss of water, the osmolarity increases and the serum sodium appears to be high. And this results in thirst and polydipsia. Patients who can drink water generally compensate for the urinary loss. If the patient can drink water, he compensate for the loss and nothing much happens to them. But those who cannot drink water, old people are there or sometimes, so if they cannot drink water due to some reason, then they can develop life-threatening dehydration. Neurogenic diabetes insipidus due to the inability to secrete ADH due to hypothalamic or pituitary disease, a very dilute urine is produced, and this disorder responds to exogenous ADH. If this patient has a neurogenic diabetes insipidus, you give the patient ADH, the patient will start concentrating the urine. Nephrogenic diabetes insipidus, the collecting ducts do not respond to ADH, or it can be due to renal disease. Either there is kidney disease of the kidney is damaged too much, it cannot reabsorb water, or the collecting ducts cannot respond to the ADH due to some reason. This disorder, and if you give in this patient, if you give exogenous ADH also, there will be no response because there is ADH is already there, but the kidney cannot function properly. So in this exogenous ADH will not respond. Then there is one thing, other thing in this context, which is called psychogenic overdrinking. Some people are there who drink lots of water, psychologically or whatever, they drink lots of water. So they also develop, they also have polyuria, they also secrete a very dilute urine. But for them, what is important is that if you restrict the fluid overnight, if you tell them to not to have any fluid for 8 hours in the night, and in the morning, if you measure the urine, see the urine osmolarity, you find out that the patient can concentrate his urine, and the urine osmolarity will be greater than 750 milliosmoles per kg. 750 is the cutoff. Greater than 750 milliosmoles per kg, if the patient is doing it, that means the patient has got psychogenic overdrinking. He is just drinking plenty of water, that's why he is secreting a dilute urine. But he has the capacity to concentrate the urine. But the patient who has got diabetes insipidus will rarely produce a urine osmolarity above 400 milliosmoles per kg. So the patient with diabetes insipidus it may be nephrogenic, it may be neurogenic, but it will not be able to dilute the urine. But a psychogenic overdrinker, if you stop the fluid intake, the patient can concentrate his urine. Now, excess of ADH. This is called, what happens, this is called syndrome of inappropriate ADH secretion, SIADH is called. Now, what happens if ADH is excess? That means lots of water being reabsorbed from the kidney. Lots of water reabsorbed from the kidney, the urine becomes less. Concentrated, very concentrated urine and very little water in the urine. Okay. Because the water is reabsorbed in the body, there is hyponatremia. Comparatively, the sodium level is the same. But because of the lots of water being in the body, the body sodium appears to be low. So there is hyponatremia. Causes of SIADH: secretion of ectopic ADH by malignant neoplasm. This is a very important thing. Small cell carcinoma of the lung, if the patient has it, some patients of small cell carcinoma of the lung, they develop ectopic ADH production from the carcinoma. And because of this ectopic ADH, the patient can develop SIADH. Or there can be drugs that increase ADH secretion, or there can be CNS disorders and infections and trauma which can cause increase of ADH secretion. Signs and symptoms would be hyponatremia, cerebral edema. Now, what happens in the blood? The body water is increased. It's taking up a lot of water. The body is reabsorbing all the water. It's not passing it out in the urine. Body water is increased. Now, but it is not the blood volume. It's not in the blood. This extra body water is not in the blood. The total body water is increased, but the blood volume remains normal. And peripheral edema does not develop. So it is not in the extracellular fluid that the blood volume, the water is increased. It is in the intracellular that the blood water is increased. So the more water present inside the cells. There is no peripheral edema, there is no pitting, there is nothing. But the cells have got lots of water. So it doesn't make much difference in the rest of our body, of our hands, legs, of our cells, of your arms, legs, and all, they have lots of water. It doesn't make much difference to us. But the brain cells, the neurons of the brain, there's a small space, limited amount of cells. Now, if the cells contain get a large amount of water in it, they swell up, there will be cerebral edema. So this increased volume of the cells is manifesting only in the brain. So there is cerebral edema, which causes neurological dysfunction. Okay? So the total body water is increased, but the blood volume is normal and peripheral edema does not develop. Okay? That's it for my lecture. If you have any query, any question, please ask me. Any question? I will send you assignments, but in your assignments, you are not writing your numbers. I want all of you to write your numbers, just your name will not do. I will not mark you present if you have written your name and no roll number.